than the medic.
Hello and welcome to another lecture in the lecture series. Today will be dedicated to Tetralogy of Fallot. So I believe by now we should know the difference between cyanotic and acyanotic congenital heart diseases. Just for a recap, we should know that cyanotic, of course, as the name implies, are the congenital heart diseases that are accompanied with cyanosis, and they are mainly characterized by right to left shunt. So Tetralogy of Fallot is one of the cyanotic congenital heart defects. It is when there is simultaneous occurrence of the following four defects: when there's right ventricular outflow tract obstruction, when there's also right ventricular hypertrophy, ventricular septal defect, overriding of the aorta, and then there might also be some other cardiac defects, like for instance atrial septal defect, and also patent ductus arteriosus, and also anomalous coronary arteries. When there is addition of atrial septal defect or patent ductus arteriosus, this is usually referred to as Pathology of Fallot. So as for the epidemiology of this defect, it occurs slightly more frequently in males than females, and then it is estimated to be in 1 in 3,000 live births, and it's the most common type of cyanotic congenital heart disease. Now, talking about the etiology, it is very sporadic. Typically it is very sporadic, and it's usually associated with DiGeorge syndrome. You remember from DiGeorge syndrome we have the acronym Catch-22. And then also Down syndrome. One of the manifestations in Down syndrome is cardiac abnormalities. And then also when there is exposure during pregnancy to alcohol, when also the mother has phenylketonuria during pregnancy, and then also in the case of gestational diabetes. So now we are going to talk about the pathophysiology. So during fetal development, there is anterior and superior deviation of the infundibular septum, and then this leads to misaligned ventricular septal defects with overriding of the aortic root and subsequent right ventricular outflow tract obstruction. The physiologic blood flow is then determined by the severity of the right ventricular outflow tract obstruction. When there is a large ventricular septal defect without significant stenosis of the pulmonary outflow tract, there is equal pressure in the right and left ventricles, and then the blood flows along the path with the least resistance. So normally we know that the left ventricle has much more pressure. So in this case, when there is a large ventricular septal defect without significant pulmonary stenosis, the blood flow is going to flow from the left heart to the right heart, so left to right shunt in this case. And then this will not be accompanied by that much of cyanosis. But on the other hand, when there is severe right ventricular outflow tract obstruction, flow from the right ventricle to the left ventricle occurs, because since there is an increased pressure buildup in this right ventricle, the pressure will now be more than that of the left ventricle, and then this will now lead to desaturated blood, or rather deoxygenated blood, entering the circulation via the aorta. The deoxygenated blood enters into the aorta because the aorta overrides the ventricular septal defect, so it is easy for the blood to go into the aorta. Now, talking about the clinical manifestations. So infants with mild tetralogy of Fallot may be asymptomatic on initial examination. Mild to severe cyanosis, which depends on the severity of the right ventricular outflow tract obstruction. I talked about this in the previous slide. So when there is mild obstruction, there is more pronounced left to right shunt via the ventricular septal defect. And then this leads to little or mild cyanosis. And when there's severe obstruction, there is a more pronounced right to left shunt via this ventricular septal defect, and this leads to severe cyanosis. Now, patients with Tetralogy of Fallot often have something known as TET spells. These TET spells are intermittent hypercyanotic hypoxic episodes with a peak incidence as 2 to 4 months after birth. And these TET spells are usually associated with psychological and physical stress. For example, when the baby is crying, feeding, or defecating. Now, these TET spells are either caused by an increased pulmonary vascular resistance or a decrease in systemic vascular resistance. Either way, it will cause an intermittent worsening of the right ventricular outflow tract obstruction and cause an increase in right to left shunting. So, in other words, these TET spells are either caused by increased stenosis in the pulmonary trunk, or when the systemic blood pressure decreases. Both ways can actually result in right to left shunting. And these spells occur suddenly and they are potentially lethal. So untreated children tend to squat, and then this squatting usually increases the systemic vascular resistance. And then by increasing the systemic vascular resistance, because you are trying to make the pressure in the left side of the heart to be more than that of the right side of the heart, that's why they squat, to increase the systemic vascular resistance. And by doing this will now cause a decrease in the right to left shunt, and then it will cause an increase in blood flow to the pulmonary circulation because the pressure in the left now becomes more than that of the right, so the blood only has one way to go. It will go through the stenosed pulmonary valve, and this will now lead to decreased hypoxemia because perfusion can occur when the blood gets to the lungs, and then this causes relief of symptoms. So on cardiac examination, we'll hear harsh systolic ejection murmur at the left upper sternal border, and also we'll hear single S2, and then there's also possible right ventricular heave and systolic trill, and then there can also be symptoms of congestive heart failure. The gold standard for diagnosis is actually echocardiography, and now medicine is so advanced that we can actually detect this case during pregnancy through this echocardiography. So if echocardiography is not done during pregnancy, it can also be done after the child has been delivered. And then on doing this echocardiography, what we are going to see is the main features of Tetralogy of Fallot, and then we are going to see quantification of right ventricular outflow tract pressure gradient, and then along with this echocardiography, supplementary cardiac catheterization may be performed. Another way to diagnose this is through chest X-ray. On X-ray, we are going to see boot-shaped heart, and we know this is due to the upturned cardiac apex and then the right ventricular hypertrophy. And we might also see decreased or normal pulmonary vascular markings, because we remember in the case of Tetralogy of Fallot, there is pulmonary stenosis or in some cases atresia. So we can see the decreased pulmonary vascular markings in case of significant stenosis or atresia. On the ECG, we'll see right axis deviation, And then also we'll see right atrial enlargement, also known as P pulmonale. Remember that P pulmonale is when the P wave amplitude is actually more than 2.5 millimeters and the duration stays normal. And then also we can also see signs of right ventricular hypertrophy. Now we can also do hyperoxia test. This test helps to distinguish between the cardiac cause and the pulmonary cause of cyanosis. In this test, the partial pressure of oxygen is measured during administration of 100% of oxygen. If the cyanosis results from right to left shunt, that's for instance Tetralogy of Fallot, there is continued mixing of the oxygenated and deoxygenated blood. And then this leads to a continuation of hypoxemia and low partial pressure of oxygen despite administering 100% oxygen. So there's no relief in this case. Now, as for the treatment, if there's a severe right ventricular outflow tract obstruction, we infuse prostaglandin E1 until surgery. We know that prostaglandin E1 is a vasodilator, and then if there is pulmonary stenosis, we can administer this to dilate the pulmonic valve or any other stenosed part of the pulmonary tract. And then in the case of TED spells, we should administer oxygen, and then knee to chest position or squatting should also be done. So knee to chest in babies and squatting in toddlers. And also we should give intravenous morphine to relieve the pain, and also intravenous fluids. If all these measures fail, then we should give beta blockers intravenously. And now for the surgical treatment, it's usually performed within the first year of life. But if this early surgical management is not possible, we have to do a palliative shunt, also known as the Blalotoxic shunt. On the right side of my slide, you can see the lady that invented this shunt. She noticed that blue babies with patent ductus arteriosus tend to survive longer than those without. And this is because many blue babies have congenital obstruction of the pulmonary blood flow. So she devised the Blalotoxic shunt that creates a passageway from the subclavian or carotid artery. On this slide, we can see that it's from the subclavian artery to one of the pulmonary arteries mimicking patent ductus arteriosus. So kudos to the lady. As for the prognosis, unfortunately, without surgery, about 50% of patients do not live past the first 3 years of life. With corrective surgery, over 90% of patients live to more than 25 years of age. That's the end of the video. Be sure to leave a like and subscribe if you haven't.